Good day, people. We're continuing on with patient positioning. So we did a series previously that has the 4 general concepts. So 1 is table make stable. 2, less table means I need to make the patient more stable. Number 3, the space between us is unstable, aka negative space. And number 4, how do I actually choose the position that I want to put the patient in to treat them most appropriately, is that I want the anatomy exposed, free to move in the plane required, and preferably visible. So we're going to do another general series here. And we're going to look at each position a little bit more specifically and just talk about the pros and cons. We did that very generally in the video about actual choosing a patient position. So the 4th video in the previous series. But what we're going to do now is speak about each position a little bit more in depth. Okay, so first, we'll talk about the seated position. In subsequent videos, we'll speak about supine, prone, and lateral. All right, and there are abilities to mix these things, but the reality is we need to start somewhere. So we'll start with the most common patient positions. So as far as seated is concerned, most motions are available for the axial skeleton, for the arms. Okay, so for the vertebral column, the thorax, the lumbar column, the cervical column, the arms, and you can treat quite well the leg below the knee. The challenge is that the thigh is in contact with the table, as is the pelvis, so you have more trouble treating them because they're more fixated. As far as your general overall motions, axial rotation of the patient, okay, so your big twists are available. So in the transverse plane, your coronal motions, aka side bending, are easily available. Extension is available, usually has to be patient driven with minimal practitioner intervention, because it's very cumbersome on the operator or the practitioner to be able to hold the patient and lift them, because there can be size differences patient to practitioner. There can just be height differences. You may not have an adjustable table, so there's issues there. But extension is freely available. Flexion, so forward bending, rolling forwards, is quite available, but it does come with some challenges, because often what you have is essentially soft tissue approximation on the front of the body. So soft tissues abutting one another, regardless of the leanness of the patient. Everybody eventually runs into themselves on the front, so often into the abdomen, but not exclusively. And there are variations within that depending on how the patient happens to be built. Again, it doesn't really matter how they're built. Eventually, you just run into yourself. Many people will speak about tension on the posterior surface as being a limiter, but more often than not, many patients experience some discomfort as they fold forwards because their hips and the pelvis is locked, and they run into their abdomen, or their abdomen becomes uncomfortable because they're basically squishing it. So now that we've had our general overview of the big motions that are available, at least from the vertebral column, and talked about the fact that the cervical column can be treated in all planes, you have to be very careful because there is less stability. So again, when we talked about patient positioning and control, we need to worry about stability. So we've already talked about the general issues with having stability with the patient in seated. What we're going to do is we're going to go ahead and look a little bit more at it, and we'll speak about the ability to treat the arms as well as the leg below the knee, and what's available there. So we'll actually provide some examples. We're not going to provide in-depth treatment options, but we'll provide examples and show that the freedoms of motion, and we'll move back to re-engage the concept of stability and of control. So in a seated position, the least amount of the patient is in contact with the table compared to the other common positions. So I'm required as a practitioner to provide more stability for the patient so that I'm better able to care for them. So we're going to move forward and look at actual demonstrations now. So here we are talking about the seated position, just a little bit more in depth. We're looking at things that are easily available to us and available to us with greater difficulty. Okay, so we look at the previous series on patient positioning, and we look at the table make stable and concepts like that. So we know that when the patient isn't seated, they're less stable, and we need to work on control more. We need to work on how well we interact with the patient so that they're safe. Okay, so as far as patient active is concerned, with respect to the torso and the upper limbs, everything is available. Okay, so what we're going to have you do is tuck your chin and roll forwards. Okay, sagittal plane's available. Here's the thing. A lot of people believe that flexion is extremely free in a seated position. I will say this, that no matter how big or small or how lean your patient is eventually they run into their abdomen and it becomes uncomfortable. So there may be more vertebral flexion available, at least in the lumbar region, than a patient will actually be able to actively produce themselves. Part of it's because even if they're lean, they run into their abdomen, but they can actively flex without all that much issue. Okay, so I'm going to have you sit up as tall as you can, look at the ceiling, stick your tummy forwards. Okay, extension is quite free. Okay, with the exception of the lower lumbars, because the patient is in hip flexion. Okay, so the lower lumbar region, you should not expect it to extend freely. If you believe that you have flexion in the lower lumbar region when a patient's seated and they extend, because it doesn't extend freely, you're forgetting that they are in hip flexion. So the lower lumbars should not flex as well, or rather extend as well. Please excuse me for mixing that up. Okay, I'm going to have you tip to the side. Movement in the coronal plane is quite freely available. Okay, so it's a good place to test this. It's a good place to treat it. Okay, I'm just going to have you twist backwards this way. Movement in the transverse plane is quite available. I'm just going to have you make a big circle with this arm. Big, doesn't matter. Perfect, that's it. Giving us some flair. So, the arm is freely mobile. We can work on the neck. The neck is available to work. The challenge is, so that was all patient active work. The challenge becomes when we go patient passive, as far as the planes are concerned. Because the patient is sitting up, the table is not here to make them as stable. Okay, I have to make the patient more stable. I have to control the patient. We've talked about that in the previous series. I run into some problems with the sagittal plane. Okay, so what I want you to do is you're going to put your fingers together behind your neck, bring your elbows together. Okay? Say we want to engage the sagittal plane to create extension. This is a common hold. I can lift them up, but the problem is, we're going to show you this. This is as far as I can lift them. Okay? Sit up as tall as you can. As tall as you can. Stick your tummy forwards. Okay? Look at how far you can go there. Now come back down to a normal position. I have a hard time getting in there, so sit up as tall as you can now. That's how much more extension he has. So I have a problem with extension. It's not that I can't do it, but it's difficult for me. So a way to kind of get around that, sit up as tall as you can. If I want to create extension for a patient, I'd get them to sit, and then I would come in and assist. Right? That's just one thing to think about. Let your hands out, because that's not fun for most people. As far as flexion is concerned, remembering what we spoke about earlier, that most people end up running into their abdomens, a common workaround for that is where people will have the patient put their feet, say, on a stool. Now, that doesn't really increase low lumbar flexion, it just increases hip flexion, so it just brings the thigh closer to the trunk. So it's not necessarily the most ideal workaround. Although sometimes it works, it doesn't seem to work as well as people would like us to think it does. Okay? So now, as far as controlling the sagittal plane, controlling flexion for the patient, when the patient rolls forward, guess what? They roll away from me. So now what I do is I take the concepts from our previous series, so the space between us is unstable, I have to lean in, I have to get close to the patient. It's not the most ideal. I can work from the front of the patient, but the challenge is it becomes quite overbearing. It can become very powerful. So I'm just going to swing around, just so you can see this. Drop your chin to your chest, roll forwards. So something of this nature. I can create more flexion. I've got lots of body contact, but this can be uncomfortable for people. They're, right there. His head's on my side. He's quite close to my armpit. Hopefully I'm smelling fresh. But the challenge for a lot of practitioners is that they will put a lot of force on the neck, and it's not ideal. So there's misunderstanding with this and misapplication. It's possible, but not ideal. So the sagittal plane is not particularly ideal. Now, you give yourself a hug. The transverse plane, quite easy to engage, quite fully, with not much issue. Okay? There's multiple ways to do that, but it's pretty easy. Let your arms down. Coronal plane, again, quite free. Okay? I can do lots of things, lots of body contact. So what you don't see on that side is my entire abdomen is in contact with my patient. You'll be able to see it here. So I get in close contact, control my patient quite well. So the coronal plane and transverse plane, quite available, quite easy to control, and get a good full range through the folded vertebral column. Now, a lot of people will like to treat ribs in the seated position. Now, it's possible, right? You'll get things such as, rib raising in a seated position. One of the challenges there is it can be quite hard on the shoulder. So if people have a shoulder issue, it's quite hard. A workaround to that is something such as this. Okay? So now I can utilize the leverage. I can get the serratus anterior to work for me. I can get some pectoral tension, and I can work through the ribs. Lots of body contact, lots of control. I can do things like work through the ribs. So there's lots available to me. But the keys as far as the seated position are that the sagittal plane is hard to work with. It's good for patient active, for patient passive it's difficult. The coronal plane, very easy to work with, patient passive. The transverse plane, quite easy to work with, patient passive. The upper limb is fairly easy to access. You can access the ribs, it's not the easiest because you have to control the patient to be able to do it, because if I want to work on the ribs, I could just end up creating rotation of the vertebral column and the soft tissue elements and not treat the ribs. So it's tougher because I essentially have to become the table. So that's just your general overview of seated. And we'll talk more about specific things within seated, specific pieces of anatomy as we go forwards.